Let's go ahead and look at common musculoskeletal injuries that include sprains, strains, and fractures, and we'll also discuss dislocations. So, a strain is an overstretching or an overuse of muscles and tendons, so muscle to bone. A sprain is a stretching or a tearing of the ligament, bone to bone. A dislocation is where the bone is displaced at the joint. There can be partial displacements or full displacements or dislocations, but the partials are called subluxation. And a fracture is a break in the cortex of the bone, and it can be classified as open or closed. Interesting, the epidemiology of sprains and strains is an impossible statistical number to record because so many are treated at home. The pathogenesis of sprains, strains, and fractures. The strain is really minor or no muscle damage, okay? So a stretching, and the patient pretty much recovers fairly quickly. Sprain is an injury to the supporting structures, so there is some injury, and they're graded 1 through 3. So a grade 1 sprain is minimal injury of the stretched fibers, and there's possible micro tears, but they're very minimal, okay? 2 is a partial tear of the ligament. It's more serious, and 3 is a full or a complete tear of the ligament. So much more serious, and often casting those grade 3 sprains for a couple weeks really helps in the recovery time. Bone injuries can result in fractures or a break in the bone, the cortex of the bone. Remember that avulsion fractures are the ligament tears away from the bone, bringing fragments with it, usually after a forceful injury. It's right here I'm going to direct your attention to fracture blister article that myself and Dr. Gentry and Dr. Short wrote and had published. It's in your module. My sister is a palm tree scientist in Miami, and she fell off a ladder from a palm onto concrete, and she had avulsion fractures. So I'll just have you glance at that article to see what a forceful injury does, and how that impact came forward. The fractures were so severe that she formed a fracture blister. Then stress fractures are small cracks in the bone, and dislocations are a pulling or a pushing of the bone out of its normal position. Clinical presentation, typically with a strain, you've got some local pain, but they are still able to weight bear. Sprain, there's generally swelling, discoloration, and pain with movement. And fractures are kind of interesting. A closed fracture, there's usually an area of pinpoint pain, but there may or may not be swelling, discoloration, or decreased range of motion. So you have to be aware of that. Although typically that's what I see, not the reverse of no symptomology, it is possible. There are generally, the patient has more severe pain with a dislocation versus a fracture because the nerves, tendons, and vessels crossing that joint are disrupted. Injuries resulting from crushing or compression should be evaluated immediately related to the neurovascular compromise. So that history is so important. And just looking at the physical forces that occurred. It is difficult to impossible to exclude a fracture without an x-ray study, and really we're talking about a closed fracture. Open fracture, it's obvious, the bone's hanging out. Physical exam, again, history has got to be very broad. It has to be very specific, the mechanism of injury with force, with focus on the physical forces that occurred. You also have to really drill down to that past medical history. Have they ever had an injury like this before? Do they have any diseases of the bone or immunocompromise? Really looking at giving you a more suspicion, or increasing your suspicion of fracture. You want to observe guarding, assess for pain and swelling, dislocation, deformity, or any open wounds. You want to assess the joint above and below the injury. You are going to prioritize circulatory, motor, and sensory function. Palpation for joint laxity should be deferred generally until you have ruled out a fracture. And then on page 994, our author gives such good information on how to discriminate between elbow injury, wrist injury, things that we're thinking about with children and adolescents, and specifically growth plates, and how that becomes an emergent situation if the growth plate could be involved, because a fracture across a growth plate could stop that bone from growing. And then how to differentiate or be more suspect of fracture of the ankle. So I do want you to look at that, and I do want you to know that information on 994, okay? I'm not going to read it to you, but you go back and look at some of those tips. Diagnostically, so often we have to order a radiograph if we because there's no way to tell if it's fractured or not fully when it's closed. But it just depends, and we're talking more of a sprain and versus fracture. Strains you can generally assess and tell that perhaps conservative measures of elevation and ice and non-steroidals before you have to think would go to a radiograph. So I'm certainly not implying that I x-ray every sprain or strain I see, but any suspicion of fracture needs to be x-rayed. You will get a diagnosis of a fracture when the break in the bone cortex is visible in two views, and I gave you an example of that at the end of this lecture. I want you to look at the diagnostic section, and you really should know the difference between angulated, transverse, oblique, spiral, green stick fractures, which are more common in kids because of their cortex is softer and impacted, and comminuted fractures. So take the time. Very brief section, but very interesting, and we should know when we read the differences. The other thing that's real important to have knowledge of is the other types of fractures you might see, such as stress fractures you will see commonly, and they occur from overuse and continued pounding to the bone. You'll often see those in athletes or very athletic adults or young adults, and those don't always show up on that initial x-ray. So you've got to bring those patients back and re-x-ray if you're still suspicious of this, because you'll begin to see the bone respond to those stress fractures, and that's how you will be able to diagnose the stress fracture. Also, injuries to the navicular, the patella, and the acromioclavicular joint has special presentations. I want you to review that. Foot fractures of the talus and calcaneus are often misdiagnosed as ankle sprains, and I can see that. Why so? So again, any suspicion, the only way to know is that x-ray. And then compression fractures of the vertebrae. And you'll see most of those in our older patients, and they're very painful. And thank goodness there is some therapy that can be done for those. They actually have some bone cement they can inject and with some of the fractures, and relieve that tremendous amount of pain. Management, if the radiograph's findings are negative, most musculoskeletal injuries will respond to price, or police. So you can review those, rest, ice, circulation, elevation. And I believe price puts protection on it. And police is protection, optimal loading, ice compression, and elevation. And nonsteroidals and elastic wraps are part of the management. Referrals for fractures or dislocations confirmed on X-ray to orthopedist specialist. Some PCPs will reduce a finger or an elbow dislocation, but if they have problems, they'll go ahead and referral. Shoulder dislocations are usually sent to the ER because these people have to be pre-medicated before the shoulder's put back into socket. And then any injury that doesn't resolve in an expected timeline. Education and health promotion is quite lengthy for people with musculoskeletal injuries and disorders. Patients and families have got to be taught to check for paresthesia, pallor, pulselessness, decreasing circulation, and paralysis of the affected extremity. Educate pain is expected to decrease, so if it doesn't, they've got to follow up sooner than perhaps even their follow-up appointment. Wraps need to be removed, those elastic wraps, every 2 to 3 hours for 15 minutes, and reapply it only snugly, not in a fashion that would decrease circulation. People with casts need to elevate those casts, learn to check for their neurovascular status. You teach them to wiggle their fingers and toes to prevent swelling. They really should put nothing in a cast, even if their leg itches, powders, or scratchers, or anything. Want to keep that cast dry and clean. Teach them that the cast can conduct cold, so an ice pack to the cast will penetrate and go and help with swelling. And then they have to know their weight-bearing status, bathing and follow-up care, and then just all realms of life. You're really teaching safety checks in the home to prevent injuries, proper gear for sports, anything to reduce the risk of musculoskeletal injury. You're going to be surprised, or maybe not, how much you're going to see musculoskeletal injury. Thank you.